few disclosures I need to mention. I'm a consultant for BioClinica. Book royalties from Elsevier, grant from AIUM, and research equipment from Harvest Corporation. So I'm going to review 4 different areas, touching a little bit on the technique and anatomy again, but then go right on to pathology and include MR correlation where possible. So as I mentioned, when you're looking at the anterior hip, other than the hip joint and labrum itself, these are other structures to consider depending on the history of the patient. Iliopsoas bursa, we mentioned, the iliopsoas, rectus femoris, and sartorius muscles, and then the groin area where the adductors attach or originate at the pubis, and we'll also look at the pubic symphysis. Now, inguinal hernias is a separate exam in itself. There are some indications where you need to perform a separate hernia exam. Most people feel that the sportsman's hernia, however, is related to a tendon problem rather than a true hernia. So if we look at the anatomy of the anterior hip, I want to just reemphasize the fact that the capsule is 2 to 4 millimeters thick, and it reflects back on itself, which explains the findings we see on ultrasound of the tissue of the femoral neck. And once again, this is where fluid will collect. This is where we'll look for fluid. This is where we'll put our needle into the hip joint. So here is the typical appearance of this capsule that's reflected on itself. Many times you can't make out the separate layers, but we know from the anatomy that's exactly what is happening. In addition to looking here for joint fluid, we're going to be looking at the labrum next to the acetabulum. Most labral tears are indeed anterior.